students, welcome to BSN 720. Today we are going to learn about respiratory failure and acute respiratory distress syndrome. Please go through the learning objectives, then we're going to skip to acute respiratory failure. So what does acute respiratory failure means? It could be either inadequate supply of oxygen or inadequate removal of CO2. Both of this can lead to respiratory failure. So one could be either hypoxemia or hypoxia, reduced oxygen. The other reason could be CO2 retention in the body or increased PaCO2 levels. One of the tests we usually do to identify respiratory failure is arterial blood gas levels. So let's look in details. What it involves is the pH level, PaO2 levels, PaCO2 levels, bicarbonate, and saturation of oxygen. So what is the difference between PaO2 and SaO2? PaO2 is the partial pressure of oxygen dissolved in the blood. Saturation of oxygen is measuring the amount of oxygen which is combined to the hemoglobin in the blood. So the saturation of hemoglobin with oxygen is what we are measuring with the saturation of oxygen. PaO2, we're measuring the partial pressure of oxygen. That's the difference between the two things. Usually, with pulse oximetry, we're measuring the saturation of oxygen in the arterial blood. Now, when we look at respiratory failure, it can happen as a result of inadequate oxygenation. That means there is not enough oxygen supply, or inadequate ventilation, which means our body is not able to expel the PaCO2 or carbon dioxide, which is in the body or in the blood. Either of this can lead to respiratory failure. So the diagnostic criteria is usually PaO2 less than 60 millimeter of mercury. We would say patient is in hypoxemia, is going to go into respiratory failure. Now, something to remember is that if you have ever sent a patient home with home oxygen, we usually do ABG test, and you see that if the PaO2 is usually less than 55, they usually qualify for the home oxygen. So something, we also send patients home on a home oxygen when they're palliative, if they have other diagnoses like pulmonary hypertension, etc. But the cutoff value usually we look at is 55. PaCO2 case, if it's above 45, that's alarming. When it's above 50, we call it hypercapnia. Usually when it's above 45, sometimes we say hypercapnia. One thing to remember with CO2 retention is that whenever our body is in CO2 retention, whenever there is CO2 retention in the body, the carbon dioxide always combines with water to form carbonic acid. So patient will be always in metabolic acidosis because of the carbonic acid formation. Acute respiratory failure can happen as a result of different pathophysiologic condition. So ventilation perfusion mismatch. That means the air, the patient is breathing because as a result of pneumonia or pulmonary edema, because there is fluid and pus in the alveoli, there is not enough perfusion happening. Oxygen is not going into the capillaries. There could be diffusion impairment. Diffusion impairment happens when there is thick alveolar capillary membrane. Like in acute respiratory distress syndrome, usually the pathophysiology behind that is when patient will lack surfactant in the oxygen, which keeps the alveoli open. So either alveolar collapse can happen, or as a result of lack of surfactant, things a tiny membrane called a hyaline membrane is formed in the respiratory tree. As a result, there is impaired gas exchange. So that's an example of impaired diffusion. This can happen with pulmonary fibrosis. There is scarring of the alveoli, so there is not enough exchange of gases happening. So that's diffusion impairment. or it can happen as a result of hypoventilation. That means there is muscle weakening. Respiratory muscles are weakened. There is not enough respiratory drive as a result of some CNS disease condition like brain injury or something. All of this can lead to respiratory failure. So let's look at this chart where it says what is hypoxemic failure and hypercapnic failure. As I said before, you will see both above 45 or 50 millimeter as hypercapnia. Let's look at hypoxemic respiratory failure. So it's really difficult to say that um, usually hypoxemic and hypercapnic failure happens together. So we don't really classify. We usually treat the respiratory failure. But if we are splitting atoms, hypoxemic respiratory failure means there is lack of oxygenation. That means PaO2 is less than 60 millimeter of mercury and PaCO2 sometimes remain normal or low. This you would see in certain disease conditions. So this happens with acute respiratory distress syndrome, pneumonia, toxic inhalations, when there is pulmonary edema or pulmonary embolism, shock, etc. Most of the time, the hypoxemia and hypercapnia kind of go hand in hand. You would see both in a respiratory failure. Ventilation perfusion mismatch happens in conditions like COPD, asthma, atelectasis, etc. So what does that mean? Roughly put, about 4 to 5 liters of blood flow through the lungs, and same time 4 to 5 liters of air flow through the lungs. So there is always 1 ml of air and gas or blood exchange happening. That's how exchange happen. But when we look at our lung structure, you would see that the apex of the lungs might have more dead spaces, base of the lungs might be working harder, but altogether, simply 4 to 5 liters of blood and gas move through the lungs. So the ventilation perfusion ratio is always going to be 1 to 1. And if there is any mismatch, that's the disease condition. Sometimes the cause could be a shunt. So what does that mean is that there is conditions like pneumonia or pulmonary edema when there is fluid in the lungs. The blood is passing through the lungs, but there is not enough exchange happening. So blood is shunting through the lungs, but there is not enough gas exchange happening. But in some other conditions, there is diffusion limitation. So blood and gases are moving because of the a large emboli. Blood flow could to some part of the lungs could be limited, or like in ARDS, when there is a hyaline membrane, there is not enough gas exchange happening. So that can happen. That's diffusion limitation. Let's look at a picture of this lung. So this is an alveoli where you see that the capillaries are around the alveoli. When we breathe, oxygen goes into the alveoli, and the O2 CO2 exchange happens between those two layers. So whenever there is collapse of alveoli, there is not enough air exchange. Whenever there is fluid here, like pulmonary edema, there is not enough gas exchange. So as a result of lack of surfactants here between the two layers, a hyaline membrane forms that also affect the gas exchange. So that is diffusion limitation. Then there could be hypoventilation as a result of any CNS disorder. So we give the patient a large dose of opioid which suppress their respiratory center. That can lead to respiratory failure. Or they had a head injury, or they had a high level spinal cord injury which affected the respiratory system. All of that can cause hypoventilation in patient. So a multitude of conditions can altogether lead to ventilation perfusion mismatch and respiratory failure. Now, like I said before, the hypoxic and the hypercapnic doesn't stand alone. Sometimes you would see both together. So you usually say when they are in hypercapnic failure, when their PaCO2 level is over 45 millimeters of mercury. That usually happens with chronic obstructive pulmonary disease. Another thing to remember is CO2 has sedating effect in the brain. So sometimes, when you had a patient yesterday, it was fine, they were walking, talking, had mild respiratory distress, but throughout the night, they kind of had CO2 retention, and when you came back for today's shift, they're not waking up. That's usually the classic picture of CO2 retention in COPD patient. Because of CO2 retention, it has a sedating effect in the brain. It kind of brings the level of consciousness down. So these are some of the changes you would see. Usually the PaCO2 level will be elevated in case of hypercapnic failure. And the only treatment for that is mechanical ventilation. No drugs can correct that, just so that you know. So if your patient is unconscious in the morning, you see that they're in CO2 retention, the next step is to move them to ICU, put them on a BiPAP or a positive pressure ventilation to do proper air exchange and then get rid of the carbon dioxide. Um, so hypercapnic respiratory failure, as I said before, you will see in conditions like asthma, emphysema, chronic bronchitis, cystic fibrosis, etc. CNS depression can also cause hypercapnic failure. So opioids, benzodiazepine, etc. can have that suppressing effect on the brainstem, which can cause hypoventilation and hypercapnic respiratory failure, which can also happen in case of brainstem infarction, stroke in the brainstem, or high-level spinal cord injuries. Chest wall conditions like flail, chills, kyphosis, severe obesity, all of that can lead to hypercapnic failure. Another conditions you usually see is muscular dystrophy, Guillain-Barré syndrome, multiple sclerosis, myasthenia, etc. So if you have a patient with one of these neurogenic conditions like Guillain-Barré or myasthenia, those are like acute exacerbation because it's acutely progressing disease condition. Then what you're going to watch for is, are they going into respiratory failure? With multiple sclerosis and muscular dystrophy, it's more slow progress. They might eventually go into respiratory failure, but it's going to be more chronic. Many patients experience both hypoxemic and hypercapnic failure, as I said before. Now let's look at the difference between acute and chronic respiratory failure. So acute, as the name indicates, it's of sudden onset and the patient could like really die pretty quickly. Chronic is more renal compensation. So one thing to remember is that whenever you have a COPD patient and if their condition is getting worse, if you look at the renal function, you will see that they're also going into renal failure because lungs are basic organ which maintains our acid-base balance on a minute-to-minute basis. But on a daily or a long-term basis, kidneys are the organs. So kidneys kind of is the long-term organs which maintains the acid-base balance. So if you don't correct the lung disease, your patient would eventually go into renal failure because the renal kidneys are trying to compensate by absorbing extra bicarbonate, etc., to maintain the pH. So you'll see that if chronic lung disease patient also are in mild renal failure, and if as their lung disease get worse, they also go into more and more renal failure. One thing to watch for. So as I said before, when we look at the blood work like pH, HCO2, pH will be abnormal in case of acute because it's sudden onset. In chronic condition, usually kidneys kicks in, so kidneys would absorb more bicarbonate to maintain the pH. So pH will be normal, but you will see that the bicarbonate levels are elevated in case of chronic respiratory failure. Something to watch for. Now, what happens with respiratory failure, right? You usually see clinical manifestations like severe dyspnea, tachypnea, hypoxemia, crackles, confusion, etc. I would say first symptom you're going to notice is confusion, restlessness, agitation, those symptoms. Because whenever there is hypoxemia, our brain cannot sustain that. Um, we cannot function without oxygen for less than a minute or less than 3 minutes, 1 to 3 minutes. So we're going to always see mental kind of symptoms, CNS signs and symptoms immediately when patient is hypoxic. Usually patient will manifest as like really agitated or restless. So this is something to keep an eye on when your patient who was okay is just all on a sudden is agitated or restless. That means they could be hypoxic. So, clinical manifestation could be sudden or gradual onset. Sudden onset you see in conditions like asthma, where there is severe obstruction of the airway. They go into respiratory failure. Gradual onset is your COPD patient, where they progresses eventually into respiratory failure if not treated. And also, those are the patients you would see that they're in also renal failure. So, one thing to watch for in clinical manifestations is that the early signs and symptoms you would see tachycardia, tachypnea, and mild hypertension, but I would also say watch for agitation, restlessness, confusion, etc., because those are the early signs you're going to see in a patient. Severe morning headache, that is because of lack of oxygenation. Also, at night, the respiratory rate is slower, so patients would have CO2 retention at night. So this is your typical COPD patient who was okay at the end of the shift yesterday, but when you came back this morning, they didn't wake up from their sleep. That's because they usually the respiratory rate is slower and they're in CO2 retention at that time. And if you check ABGs at that point, you will see that their PaCO2 levels are really high. Late and very unreliable sign is cyanosis. So cyanosis, you cannot depend on that. And it just doesn't happen really quickly, or it's very unreliable. So what happens with hypoxia and hypoxemia is that again, when our lack of oxygen supply will lead to anaerobic respiration, so you'll see that they are going into metabolic acidosis. CO2 retention also lead to metabolic and respiratory acidosis. So always with CO2 retention, you remember that they're going to be in acidosis, hypoxia, also acidosis. GI symptoms, usually as a result of ischemia and decreased blood supply to the GI tract. Other clinical manifestations would be rapid shallow respiration patterns. So whenever there is respiratory acidosis, our body's trying to compensate by breathing at a rapid rate. That's like a body's mechanism. You would see that the patient is always in a tripod position or like in a semi-Fowler's or Fowler's position to help with the breathing. You'll notice that the patient is dyspneic. One of the classic symptoms of dyspnea is that they are not able to complete a sentence. Another thing as a nurse to keep in mind is that when your patient is in respiratory distress, their nutritional demands are high and also they don't have enough, they'll always lack enough nutrition because you have to catch your breath to swallow something. So if they're really dyspneic, they probably won't be able to tolerate enough food. So something to keep in mind. So they always have difficulty speaking and also they'll have difficulty swallowing food. Retractions in the intercostal muscles, change in the inspiration expiration ratio. So normally we have double the expiration time than inspiration. So it's 1:2 normally, but you will see that patients who are in respiratory distress will take more time to expire, like 1:3 or 1:4 would be the ratio, especially your COPD patient. If you notice, they take longer time to expire. Then what are the diagnostic studies? Our basic and the biggest thing which we can diagnose this is by doing ABG analysis. Chest radiographs will show signs of atelectasis or pneumonia. CBC, blood culture, electrolytes also will show changes. You would see arrhythmias as a result of that changes too. So ECG changes, urine analysis. One of the biggest tests we do is the ventilation perfusion scan. This is one of the diagnostic tests for pulmonary embolism. Also, if we do pulmonary angiogram, you could see that they have that clot in the lungs. So these are some of the tests we do. Now, nursing management. Usually the signs and symptoms are earliest manifestation, as I said before, as the biggest sign of hypoxemia is restlessness. So if your patient who has been okay is acting weirdly or have some agitation, restlessness, check their saturation, you would see that they have low saturation. And that's all because of the hypoxia to the brain. Let's look at some of the interventions. Overall goals, we look at the ABG values, analyze it with baseline. Sometimes they do have a series of ABG values done to match or to compare. Breath sounds, also always notice the patient's breath sounds because you can then tell any alterations in lung sounds or decrease air entry to the one area means that part of the lungs is collapsed. Dyspnea, cough is some of the a good sign because if a patient can effectively cough, they can actually clear their secretions. Early recognition of signs and symptoms of respiratory distress is really important in management. As it progresses, it becomes really, really hard to manage. So oxygen therapy to maintain PaO2 levels and saturation above 90%. The gold standard or the normal saturation should be 95 or above. At least in patients who are in respiratory distress, we want to maintain it above 90%. And our goal is to correct the hypoxemia. We can give oxygen through nasal cannula or through a mask. So one thing to remember, when we give oxygen through nasal cannula, we kind of measure it in liters per minute, like 1 liter, 2 liter, 3 liter, etc. When we give it via a mask, we sometimes say 30% oxygen, 28% oxygen, 35% of oxygen, etc. So there is no one-to-one conversion for this. You cannot convert your 1 liter into percentage. What the percentage means is that our atmospheric air has 21% of oxygen. So by using a mask and calibrating that, what we're doing is we're giving more percentage of oxygen through the mask. So if we're putting it at 28%, that means that air which we are providing has 28% of oxygen in it. And if we're moving up to 35, that means it has 35% of oxygen. And sometimes we give 100% oxygen before suctioning in some certain procedures or if they go into respiratory arrest. So that's what that percentage means. Our normal percentage of oxygen is 21 in atmospheric air. Then the supplemental air we're giving has certain percentage depending on what we are calibrating it to. So some of the mask would say a conversion on it depending on the company, but theoretically there is no ideal conversion of liters into percentage. But if you ask me, if your patient is on like 5 liters of oxygen, it's roughly around 35 to 40% of oxygen. So if we are replacing cannula with a mask and you're putting, so your patient was on 5 liters of oxygen, you put them to like 28% of oxygen, that's lesser than the 5 liters, so it wouldn't work. So you would see that the patient sats didn't go up because It's lesser than that percentage. But some of the newer product will say on it the percentage and the liter sometimes. So good to watch that too. When you work as a nurse, it's good to look at those values and see, okay, am I doing it correctly? That's just a practical application of that. Now, other things which we can do is mobilization of secretions, so suctioning, augmented coughing, uh, postural drainage, etc. So suction, augmented coughing is cough assist machines. We use that to help them clear their secretions. So normal cough requires a deep inspiration, closure of the glottis, and strong expiratory contraction. So sometimes the respiratory therapist will give percussions to do augmented coughing. This is a picture of that. It's called cough assist. Manual assisted cough, nurse or a therapist, usually a respiratory therapist, applies external pressure to the abdomen or the chest wall with exhalation. So we correlate that with their inspiration and expiration. When they expire, we just give compressions on the or pressures on the chest wall. There are also mechanical cough assist machines, which also deliver positive pressure to inflate the lungs and help with the, followed by negative pressure, which would stimulate the cough. So these are machines, but you can also do it two ways, either manually or using a machine. Breath stacking is another method you would see therapists using, because they're asked to take a couple of small breaths without exhaling, and then or we use a bag valve mask. You have seen the ambu bags which we compress, or and then help with the exhalation. So difference between augmented coughing and chest physiotherapy is both are used in expelling secretions. Um, so what we do with the augmented coughing is that increases the expiratory airflow and forced coughing. But in the other technique, in the chest physiotherapy, you do like mechanical movements, either percussion, compression, etc., to move the secretions out. So that's the difference. We're not going to ask you more about that. Just wanted you to know the concept and what it involves. So basically, chest physiotherapy also includes sometimes postural drainage. It helped to move the secretions up. The other one helped to get the secretions out of the system. Now, respiratory therapy include two type of ventilations. So old classification, if we classify ventilators, we have two different type of ventilators. One is the negative pressure ventilation and the other one is called positive pressure ventilation. What negative pressure ventilation is, you're never going to see that in your lifetime. This was the very old method. I don't know if you've watched old movies where you would see the patients with polio be connected to like a machine lung or like an iron lung. So the whole chamber provides a negative pressure which pulls the chest wall up, which make them breathe. So that is negative pressure ventilation. That's so outdated. You would never see that. What we see in our clinical practice is positive pressure ventilation. What it does is that it keeps the alveoli open using a positive pressure. So from that iron lung big machine connected to a person to just nasal cannula, we can provide positive pressure through a nasal cannula. I'll show you that in a picture next slide. So this is one of the non-invasive positive pressure ventilation, where we provide positive pressure or BiPAP. Bilevel positive airway pressure. So this is a picture of a BiPAP machine where we kind of give them extra positive pressure to keep all their alveoli open. So this is what you're going to see in your daily life. You will never see that negative pressure. Forget that I told you about the negative pressure. But I just want you to know in perspective the difference between the two. So we always use something called positive pressure ventilation. So an example of this positive pressure ventilation, non-invasive technique. We're not putting an artificial airway in. We're just providing that positive airway pressure using non-invasive technique to keep that airway open. So both during inspiration and expiration, the airways are kept open. So we're going to do IPAP, which is inspiratory positive airway pressure. And when they also exhale, there is some amount of positive airway pressure. So the inspiratory positive pressure is more than the expiratory positive pressure. There is still a variation of the positive pressure. One is higher, expiratory pressure will be lower, but there is enough positive pressure to keep the airway open. The main goal of that is that their alveoli doesn't collapse. It keeps open so that there is enough air exchange. This is the usual method you would see in patients with CO2 retention, etc. So other thing for management is medication therapy. So we give bronchodilators for bronchospasm. So if your patient is in severe asthma, we're going to give them short-acting and long-acting bronchodilators to keep that open. Some of the examples are Ventolin, aminophylline, theophylline, all of those medication. Then steroids, that also reduces the inflammation in the respiratory tree. Then diuretics, which can help to reduce the pulmonary edema by expelling the water from the body. So some of the medications are diuretic, nitrates, etc., depending on the underlying disease condition too. So if this pulmonary congestion is caused by heart failure, then we treat the heart failure. So we treat the underlying cause. Antibiotics in case of pneumonia. Then we do give medications for anxiety and pain, but very cautiously. So benzodiazepines are not the best medication, or opioids are not the best medication in case of respiratory distress, but we do use that in limited amount to treat some of the anxiety and the pain. But then you should be very cautious when we give those medication, and we usually probably use a lower dose compared to other patients. So basically what we are doing is going to treat the underlying cause to treat the respiratory distress. Now, nutritional therapy is really, really important in case of respiratory failure. As I said before, one of the things which we always neglect is the nutrition, and those patients do need extra calories, so enough protein and energy to maintain their muscle strength and to recover from this condition. So we either give them enteral or parenteral nutrition. Especially in extreme respiratory distress, it is better to give short-term parenteral nutrition, because which help with the nutritional status of the patient, and also they don't have to worry about the eating, because in severe COPD patients, you would see that the patients are not able to tolerate any oral food or any respiratory distress. Something to keep in mind. Now, that is about respiratory failure. I think I do have some questions. This is all about preventative strategies, etc. I do have questions. Hypoxemic respiratory failure is most likely to occur in patient who has which of the findings? Respiratory muscle paralysis, thoracic trauma with flail chest, massive pulmonary embolism, slow, shallow respiration as a result of a sedative overdose. So in this case, the answer is C. because hypoxemic failure is also referred to as oxygenation failure, which happen as a result of pulmonary embolism. There is not enough blood supply to get the oxygen which is in the lungs. So sedative overdose, respiratory muscle paralysis, flail chest, all of that are hypercapnic because the body is not able to remove the CO2. Now, a patient with severe chronic lung disease is hospitalized with respiratory distress, which finding should cause a nurse to suspect rapid decompensation of the patient. SpO2 89, blood pH 7.33, agitation, confusion, PaCO2 of 48. This I put in as a tricky question. As I said before, agitation and confusion is some of the signs which happens at the earlier stage, and you have to always keep an eye on that. So next condition is acute respiratory distress syndrome, which is a life-threatening form of acute hypoxemic respiratory failure. So what happens with this is that there is widespread inflammation and injury to the alveolar capillary membrane, leading to impairment in gas exchange. And this also does not respond to oxygen supply or supplemental oxygen. The reason for that in ARDS, what happens is that sepsis or trauma or some inflammatory trigger increases the capillary permeability. As a result, the protein which is in the capillary membrane will sweep into the alveoli, which causes the loss of surfactants, which keeps the alveoli open all the time. So as a result of that, a membrane called the hyaline membrane is formed. This completely cut off the oxygen moving across those membranes. So that is the biggest concern in this case, which lead to hypoxemia. So which usually happens acute onset within days of sepsis or trauma. You will see that severe hypoxemia happens despite oxygen therapy. So no matter how much oxygen we're giving, this patient has lost their permeability of that membrane, and that membrane is not working. The alveolar capillary membrane is damaged completely. So no matter how much oxygen you give to the patient, it's not going to work. They're still going to be hypoxic. And that condition is called acute respiratory distress syndrome, or ARDS. Eventually, if we don't treat this, this hyaline membrane which formed will become scar tissue. So when a patient go into acute respiratory distress and then they recover, their lung capacity is never going to be the same. Part of it will recover, but they are not going to completely recover from the condition, because within a week, maybe in 2 to 3 weeks, the patient's lungs become more fibrotic. So once that fibrotic change is happening or the scar tissue is formed, it's not going to recover. So that is acute respiratory distress syndrome. Let's look at the risk factors: severe pneumonia, aspiration, pulmonary contusion, sepsis, pancreatitis, massive transfusion reaction, trauma. All of that can lead to lung injury. What happens is that the PaO2 levels are very low. Now, PaCO2 may be normal or slightly elevated at a later stage. pH might show a respiratory alkalosis. Eventually, they go into, so respiratory alkalosis happen when there is rapid respiration. Early signs are usually respiratory alkalosis, but at a later stage, it becomes decompensated. So oxygen cannot effectively cross the bloodstream, which leads to respiratory failure, pulmonary hypertension, right-sided heart failure. Usually these patients are in ICU on a mechanical ventilators. We're going to learn mechanical ventilators in the next class. So it's an acute inflammatory lung injury. If we look at the ABGs in this patient, um, e either it could be acidic or alkaline. PaCO2 not usually the best indicator to look at. Here in this case, it's PaO2 and the PaO2 level is always lowered. Then what does our kidneys do? Try to compensate and reabsorb more bicarbonate. So if you look at the respiratory failure pattern here, you would see that PaO2 levels are low. PaCO2 sometimes initial stages it might be normal, but it then become elevated. pH will definitely drop. Bicarbonate will increase. Chronic renal failure is something else you have to watch for, and then eventually lead into failure. So how do we interpret this value? 7.31, patient is metabolic acidosis. PaCO2 is 38, so it's not that bad, but PaO2 is 60. That means they are in hypoxic stage and there is poor tissue perfusion. So when you get a result, always look at that in a pattern. So what type of respiratory failure is this? In order to understand that, we have to look at the PaO2 and the PaCO2 level. So even though the O2 levels are low, you see that the CO2 levels are very, very high. So I would say this is hypercapnic failure, because if whenever it goes above 45 or 50, the patient CO2 levels are up, then we call it hypercapnic failure. Nursing assessment priorities are always airway, breathing, and circulation, regardless of that. So first and foremost, we worry about the airway, and then the breathing, and then the circulation. Early signs of deterioration, as I said before, the thing to watch for is restlessness, agitation, and confusion. So any sign of cerebral hypoxia, tachypnea, tachycardia, racing CO2 levels, all of these are significant. Now, interventions for patients who go into respiratory failure is high flow oxygen. Regardless if they're not responding, we're still going to give them 100% oxygen. Positioning, continuous monitoring, and escalation of the patient. Most likely they do need intubation and mechanical ventilation, because two things you have to remember about respiratory failure is that they definitely need respiratory support. So they should go into ventilation or mechanical ventilation support as early as possible. And the other thing you have to watch for is that they need continuous cardiac monitoring. So they always need higher level of care. So another thing, when we learn about mechanical ventilation, you're going to learn about that anyways, is that as soon as we attach a patient to a mechanical ventilator, right after that, our goal is to support the respiration and also safely wean them off. Because the more they are on a mechanical ventilator, they're going to have more poorer outcome. So as soon as we support them, it's the best outcome. And also as soon as we have to wean them off that mechanical ventilators. So we'll learn about positive and expiratory pressure. That is what we were talking about initially. Even at the end of expiration, the patient has to have positive pressure in their airway so that it prevents the collapse of the lungs. So whenever we give artificial ventilation or non-invasive type of ventilation, we always have an inspiratory positive pressure and an expiratory positive pressure. Both are positive pressure, but there is some variation to help with the inspiration and the expiration, but it's always going to be positive pressure in the airway. And the goal for that is to keep the airway open so that the patient doesn't go into respiratory collapse or alveolar collapse or collapse of the lungs. Other name for that is atelectasis. Now, we're going to learn in detail about the ventilators in next chapter, which is about mechanical ventilation. So I won't worry about that or just go over this, but we're going to learn in detail. And we'll also talk about the end of life care at that time, weaning off the patients off a mechanical ventilator.